Hello and welcome. In this second part of our lecture on drugs to treat systemic hypertension, we'll focus on sympatholytic agents, vasodilators, and clinical combinations used in different hypertensive scenarios. The objectives of this lecture are shown. Let's start with the brief discussion of sympatholytic drugs or sympathetic antagonists. These can interfere the sympathetic activity at different levels, centrally or peripherally at adrenergic receptors. Major groups include centrally acting agents like methyldopa and clonidine, or peripherally acting alpha and beta adrenoceptor blockers. This topic is discussed at a greater length in our autonomic nervous system pharmacology series. Alpha-methyldopa is a centrally acting sympatholytic by virtue of its alpha-2 agonist activity and also acts as a false neurotransmitter. It forms alpha-methyl-norepinephrine, which replaces norepinephrine in vesicles and also stimulates central alpha-2 receptors, thereby reducing central sympathetic outflow. Important side effects include galactorrhea and gynecomastia due to elevated plasma prolactin levels. It's among the safest drugs for treating hypertension in pregnancy, though it may cause a lupus-like syndrome. This slide shows the cardiovascular effects of alpha-adrenoceptor stimulation and inhibition. Blocking alpha-1 receptors leads to arteriolar dilation and reduced total peripheral resistance. This is especially helpful in elderly patients with arteriosclerosis and in systolic hypertension. Additionally, alpha-1 blockers relieve urinary obstruction in men with benign prostatic enlargement, a very practical dual benefit. Alpha blockers are divided into non-selective and selective agents. Non-selective blockers include phenoxybenzamine and phentolamine. While selective alpha-1 blockers include prazosin, doxazosin, terazosin, and tamsulosin. Alpha-2 blockers like yohimbine are rarely used clinically. Clinically, selective alpha-1 adrenoceptor blockers are second-line antihypertensives. They're particularly useful in hypertensive men with prostatism, and in conditions like Raynaud's phenomenon or pheochromocytoma. Phenoxybenzamine is the classic choice in pheochromocytoma to prevent unpredictable catecholamine surges. The main adverse effects of alpha blockers are orthostatic hypotension and a resultant reflex tachycardia, especially after the first dose, the so-called first dose phenomenon. Other effects include nasal congestion, nausea, and vomiting when taken orally. Now let's look at the beta adrenoceptor system. Beta-1 blockade decreases heart rate and contractility, thereby lowering myocardial oxygen demand, useful in hypertension and ischemic heart disease. It also reduces renin secretion, linking beta blockers to ROS modulation. Beta blockers are classified by receptor selectivity, intrinsic sympathomimetic activity, ISA, or partial agonist activity, and membrane stabilizing activity, MSA, or sodium channel blocking activity. This slide shows how each of the beta blocker division is grouped on the basis of ISA and MSA. The most important ones are cardioselective agents like atenolol, metoprolol, and bisoprolol, which primarily act on beta-1 receptors, while non-selective ones like propranolol also block beta-2 receptors. The alpha-beta blockers are especially useful when a more profound blockade is needed in the patient. On the cardiovascular system, beta blockers lower blood pressure in hypertensive patients, reduce conduction, negative dromotropy, contractility, inotropy, and heart rate, chronotropy. They also decrease excitability, bathmotropy. Unopposed alpha activity may lead to paradoxical vasoconstriction, especially if used alone in conditions like pheochromocytoma. Metabolically, beta blockers blunt catecholamine-induced lipolysis, reduce HDL, and increase VLDL, although these effects are less with partial agonists. They also inhibit glycogenolysis, so use caution in diabetics, but they are not absolutely contraindicated. Careful monitoring is sufficient. Major adverse effects include myocardial suppression, which can sometimes be managed with atropine, glucagon, or pacing. They may cause bronchoconstriction in susceptible asthmatics, and rebound hypertension if stopped abruptly. In insulin-dependent diabetics, beta blockers may mask hypoglycemia symptoms such as tremors or palpitations. Lipid-soluble agents like propranolol may cause sedation or depression. Some may cause mild erectile dysfunction, though this is uncommon with selective agents. The overall benefit-to-risk ratio remains strongly in favor of use when indicated. This table shows typical drug combinations in systemic hypertension with comorbidities. Note that angiotensin system inhibition remains central to all regimens. Take a closer look and ask yourself why a certain combination is indicated in the presence of a given comorbidity. Now moving to vasodilators, these drugs directly relax vascular smooth muscle. Some are used orally for chronic hypertension, others intravenously in hypertensive emergencies. They are often combined with beta blockers to prevent reflex tachycardia, except when the vasodilator is a calcium channel blocker. Hydralazine is an arterial dilator used in resistant hypertension and chronic heart failure. Its precise mechanism isn't fully known but involves decreased intracellular calcium and possibly increased nitric oxide release. Side effects include headache, flushing, palpitations, and a lupus-like syndrome, especially in slow acetylators. Minoxidil acts by opening potassium channels in vascular smooth muscle, causing hyperpolarization and relaxation. It's a powerful arterial vasodilator used in severe hypertension. Notable adverse effects are edema, reflex tachycardia, and hypertrichosis, hence its topical use for alopecia. Diazoxide works similarly but is less common now. Sodium nitroprusside is a potent IV vasodilator acting through nitric oxide release, leading to rapid reduction in both preload and afterload. Phenaldipam, a dopamine D1 receptor agonist, causes rapid vasodilation, making it especially useful in hypertensive emergencies. However, it can raise intraocular pressure, so it's contraindicated in glaucoma. This illustration shows how blood pressure is a function of two factors: cardiac output and peripheral resistance. Various factors control or influence one or both of these factors, and we use drugs to adjust one or both of them in short term as well as long term to keep blood pressure in optimum range. Take a closer look. Briefly, chronic hypertension is best managed by starting with ACE inhibitors or ARBs. In older or African patients, calcium channel blockers are often preferred. Beta blockers, alpha blockers, and diuretics are added as needed. In pregnancy, methyldopa, labetalol, or nifedipine are safe choices. In acute severe hypertension, intravenous vasodilators such as hydralazine or nitrates are the mainstay. Always remember to tailor antihypertensive therapy to the patient's response, comorbidities and risk profile for optimal outcomes. And know clear and well that it's a continuous process. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!